I'd like to thank all the speakers. We've got some time for some questions here, and thanks for sending your questions in. We're going to start with Dr. Terry. There's some interest in your hybrid technique.
Wonderful.
And some questions about how you manage the peripheral flange. Do you suture it? Do you use an air bubble? Can you describe your technique?
So with the technique, the peripheral flange, we carry it out as far as we can so we can get as much of a peripheral flange as we can, at least a millimeter, half 2 millimeters. At the end of the case, I do put an air bubble in there to try and push that flange up, hoping that there's some endothelial function left on the peripheral flange to actually give me some adhesion. But actually what mostly happens is the flange does not adhere to the peripheral donor cornea. It simply sits next to it. And you'll see on slit lamp a space between your donor tissue and your flange and another space for your angle. And even a very narrow-angled patient, I did this procedure 3 months ago, and everything is fine. The flange does not fall back onto the iris, as I was worried about, but I've not seen that happen in any of the 3 or 4 cases we've done. In terms of suturing, one thing I didn't mention is that you try and preserve the peripheral limbal stem cells. So I'll do a dissection on the surface to get as much peripheral corneal and conjunctival stem cells as I can, recess that all back, and then trephinate down onto the sclera and do the procedure. We suture with 90 nylon because it's scleral sutures, and they have very little astigmatism because you're so far from the visual axis with your compressive forces.
Thank you, Mark. Kathy, not surprisingly, we have a lot of questions about DSO, and maybe Marion wants to comment too, but could you give some kind of details about your surgical technique and your postoperative care, how long you keep them on steroids, when you discontinue the steroids, etc., and also the questions about the different types of ROCK inhibitor as well?
So the surgical technique, we know from the folks at Mass Eye and Ear that if you have a smooth stripping technique, it seems to have a much higher likelihood to clear. I have been using Mark Gorovoy's forceps recently, which I really love. No financial interest there. They really make it easy to do the surgery, easy to control the area of stripping. But there's lots of different ways. I think Dr. Maxey has a different technique. In terms of steroids, it depends on if I'm doing it alone or with cataract. I have seen some cases of CME if it's associated with cataract, so I tend to keep them on steroids longer than a typical cataract if it's combined, and if it's not, if it's DSO alone, usually I will get them off the steroids within about 3 weeks or so. I only have experience observing patients on Reposidil. I have not used Notarsidil. There are some differences in pharmacokinetics, which Rho kinase isoform they inhibit.
Marion?
As far as surgical technique, I like to strip using the Teflon INA tip, as I showed yesterday. It's really just like doing a capsulorhexis. We call it a desmetorhexis. It's just upside down. There are forceps like the Gorovoy forceps, but since I've got the eye filled with the viscoelastic, I like to use the INA tip. I find I get good control in a nice round strip. I've been doing this under an IND, which is only for Reposidil. There is at least one other Rho kinase inhibitor, Ropressa, and there are some others that are under investigation, other molecules under investigation. As far as the steroids are concerned, I've had most of my cases combined with cataract surgery. And at the end, I give them a subconjunctival injection of 3 milligrams of triamcinolone acetonide and only keep them on topical steroid drops, QID for 1 week and BID for the 2nd week. As far as the dosage of Reposidil, or Glanatec, I don't know the answer. I currently have a study looking at TID versus 6 times a day, and I have this inkling that we may be better off using it a little less often than the 6 times a day that Greg Maloney used in rescuing the 2 original cases described. The reason I think that is that Dr. Kinoshita's done some studies on Repositol, and it seems like the effect of each drop on the endothelium lasts for 6 hours. So perhaps we don't need quite such a frequent dosing of 6 times a day. But these are just few of the many questions we have yet to answer about this.
Thank you. Deepika, you mentioned the use of intraoperative OCT to help with DMEC orientation without stamping. Does the OCT ever get it wrong?
Now, the thing with intraoperative OCT is that actually very few surgeons, only a small proportion of surgeons have actually got to experience it. In Auckland, we don't actually have the system, so I can't answer that from personal experience. I can only talk about anecdotal, but I don't know if any of the others on the panel have experience.
Yeah, we use it routinely. We don't stamp, we don't do anything, we just inject it in. And the only time you have problem with the OCT is if there's a lot of blood in the anterior chamber. It creates like a snow that you can't see through. So that can be an issue, but otherwise it works great through cloudy corneas and so forth. And there is a difference between the different machines. I'm actually a consultant for Hog Strite, and with theirs it works very nice in the ocular, which makes a big difference. But there's 3 different companies that have those, and you ought to go on the floor and check them out.
Geeta, you gave an amazing talk there, and can you comment on the difference between the Lucia and the Boston K-Pros, and also what is your post-operative regimen, especially in terms of antibiotics?
Thank you, Dr. Sanjay. So the Lucia type 2, the Lucia keratoprosthesis is an economic variant of the Boston keratoprosthesis, both the type 1 as well as the type 2, which has been specifically designed by the Boston K-Pro Foundation for developing countries like ours. It has a titanium backplate. And it has been designed especially with the type 2 keratoprosthesis to protrude out through the mucosa, unlike the Boston type 2, which protrudes out through the skin. The antibiotic regimen for patients is different for different types of K-pros. For the type 1 keratoprosthesis, we have these patients on 4th generation fluoroquinolones, which are continued indefinitely, along with vancomycin eye drops, which are also used 4 times a day, and then 2 times a day is continued indefinitely. These patients are kept on topical steroids and tapering doses in the immediate postoperative period, and then they're again kept on a single time a day or stopped, but after a prolonged period of time. In India, because we're worried about infections, we do give a course of antifungal agents once a month for the first 5 days of the month, but that's something that we have designed for our set of patients.
Thank you. I'd like to thank all the speakers, and that concludes this session.